Hello there, I'm Dr. Matthew Sayers, and in this video I'm going to take you through neonatal resuscitation, or more accurately described as assisted transition, in Antrim Hospital. The first thing to say is this video is designed for doctors who will not be regularly attending deliveries, such as F2s and GP trainees and PEDS ST1 to 2 doctors. However, if you're likely to be constantly attending deliveries, I'd strongly recommend that you attend a neonatal life support course, which will go over all this, but in a lot more detail. I am an NLS instructor, and all the advice given is similar to the NLS course, but you'll get a lot more practical experience by attending an NLS course. These are run in a number of hospitals across Northern Ireland, but are run in Antrim Hospital. So if you're interested in this, please contact Patrick Dugan, and I'll put his email address on screen now. So I'm here in Delivery Suite in Antrim Hospital, and this is our neonatal resuscitator. You may have seen other neonatal resuscitators in other hospitals, but these are slightly different. So I'll just take you through how to set this up now, as that's the most important thing that you need to know when attending a delivery. In Antrim, ENNPs will be generally attending all deliveries, but this is just a guide in case you're assisting them, or you're assisting a registrar, or for whatever reason the ENNP isn't present and you're attending the delivery. This is the resuscitator in Delivery Suite. There's a slightly different one in theatres, but the same principles apply, and you can use all the same equipment on both of these. So first of all, we'll pull down the resuscitator. You can see there's a handle there and a stethoscope attached to it. And we pull it down until it's nice and flat, and we will bring this around like that. So it's very important. First thing to say is when you turn on a resuscitator, this must be in the correct position before use, otherwise it won't turn on properly. So the next thing we do is turn on the resuscitator. You can see there's a power button at the top that we turn on, and then we press the light to turn on the light. You can see there's a power setting, and this controls the ambient heater. It's important that babies stay warm during a neonatal resuscitation, so you can increase the power to 100%, which will provide a lot of ambient heat here. The next thing we need to do is get towels out. It's very important when you are resuscitating or transitioning a baby that you dry them thoroughly, and this is often all that's needed in a neonatal delivery. So you can see there are 2 towels, we need at least 2, and if you set them under the heat like this, they will warm up and get really nice and warm and toasty for the baby whenever you're drying them. So we'll set these out first of all. Continuing the theme of heat, head loses a lot of heat, so we need to get some hats. So you can see at the top, there's a hat there, so we'll put one out. There's ones of different sizes for different sizes of babies, and that's obviously very important. Next thing I'm going to demonstrate is the Neopuff system on the resuscitator. You can see the Neopuff here. The Neopuff is the main thing that we use to provide inflation breaths and ventilation breaths for babies. The first thing we need to do is turn on the oxygen to 8 litres, and this is what powers the Neopuff. You can see we have the tubing, and then we have the mask. We'll talk about masks in a little second, but first of all we'll take the mask off. You can see on the screen the pressures that are being delivered are shown. So for a term baby, which is what we'll assume you're mainly resuscitating in Antrim, we'll use 30/5. So first of all, I'll fully occlude the mask, and you can see there on the screen that pressures of 5 are being delivered. And then if I put my finger over the white part of the top like this, you can see on the screen it's actually delivering slightly over 30. If this is the case, we turn this knob to reduce it slightly, so you can now see it's delivering 30/5, which is perfect. So that's the pressures are fully set up. The mask, you normally get a mask like this, maybe one size bigger. This is maybe for a slightly smaller baby, but you can see there's a number of masks available of different sizes, so make sure you have a number of different size masks available. The next bit of equipment you will need is a yanker sucker. That's because there's often mucus or meconium in a baby's mouth that you might need to remove. So the suction is on this side. First of all, turn the knob like this until there's an adequate amount of suction, and then take your suction catheter as shown. As most of you are probably aware, going like this will not suck anything. You need to occlude the top, and then you can see there's pressure being put. You can see on that there's pressure being included. When you are suctioning a baby, only ever do it under direct vision. Do not blind suck in a baby's mouth, and only suck if there's something to suck out. Other miscellaneous bits of equipment that you might need, but we don't normally get out routinely, is there some iGel airways along with laryngoscopes and tongue depressors in case you need to insert an iGel. We don't routinely use Goodell airways for airway management anymore, but again, there are other videos on neonatal iGels if you need them, but generally a senior staff member will assist you in that. And the other thing is a SATS probe, which is very important if there is any sort of resuscitation, and posy wraps can sometimes be helpful to get better pickup on neonatal SATS probe. So once you've got all that equipment, ideally this would happen before the delivery. You're now ready to do the facilitated transition of the baby. When the baby is about to deliver, make sure you have an apron and gloves on, and you have the stethoscope from the baby's resuscitator ready to listen to the heart. When the baby is born, there will nearly always be delayed cord clamping. This is very beneficial to a baby, and once the delayed cord clamping, normally for around 1 minute, has occurred, the baby's cord will be clamped and they will be brought over to the resuscitator. In theatres, a scrubbed individual will bring the baby over as they'll be taking the baby out of a sterile field. In a delivery suite setting, an apron and gloves is sufficient. You don't need to scrub for that. The baby will be delivered onto the resuscitator with the head up towards you. The first thing you should do is dry the baby very, very well. So the way, sometimes the resuscitator will do that. So the way we dry a baby is to dry all parts of the baby completely, their back, their limbs, their head, and then we get rid of that towel, which is dirty, and then we wrap the baby, swaddle them well, like this, so they're completely covered on all sides, but their chest is exposed. And then we take our hat and put it on the baby's head, allowing them to stay really warm while we're resuscitating them. You can see on the resuscitator the power is still at 100%. So now the baby has been dried and has its hat applied. Whilst we're doing that, and also slightly after, we want to assess 4 things. The first thing we want to assess is the tone. Is the baby floppy, or are they moving spontaneously? The colour, is the baby nice and pink or blue but starting to pink up? Or are they pale or blue all over, which is more concerning? Is the baby crying or making any spontaneous breaths? And the final thing that we will get by listening is, what's the baby's heart rate? Obviously, we're not expecting you to know the exact heart rate. That would be very difficult to estimate. But when we listen over the heart, we're trying to strategize or stratify, is the baby going at less than 60 per minute, which would be like, is it between 60 and 100, which would be, or is it greater than 100, which would be like, if the baby's heart rate is good, then that's a very reassuring signing, and that baby is almost certainly going to transition normally without any intervention. If the heart rate is less than 60, that suggests that intervention is required. So the first thing is, if you're by yourself, you need to get help at this point. So call one of the midwives to assist you or ask for senior support. The next step is to open the baby's airway. So the airway in a baby is not open by fully extending the neck. You're looking for a neutral position. And overextending the neck is a common reason for poor airway. So we'll get the baby's head in a neutral position. We then take our mask, which you can see as shown. We roll the mask over the baby's nose and mouth. In reality, this is probably a bit small for the baby, but rather than using another one, I'll just work with it for now. You put 2 fingers over the hard plastic part of the mask and 3 fingers along the line of the baby's jaw, and push the mask down and pull the jaw in, creating a tight seal, making sure that you retain the neutral position at all times. You then give 5 inflation breaths. Inflation breaths are to open the baby's lungs, which are full of fluid, and often this is all that's required. They don't need anything further than that. Inflation breaths take place over 3 seconds. So I'll show you how we do them now. So 1, 2, 3, 2, 2, 3, 3, 2, 3, 4, 2, 3, 5, 2, 3. Whilst you're doing this, the temptation is to look at the neopuff and see if the black arrow goes up or down, but this isn't what you should be doing. You should be looking entirely at the baby's chest. It's common for you to not see any airway rise in the first 1 or 2 breaths, but you should see chest lift with the breaths towards the end of it. If you don't see chest rise, then you have not adequately aerated the lungs and you need to take further intervention. After your 5 inflation breaths, you do your same assessment again, assessing the colour, tone, heart rate and respiratory effort of the baby. If at this stage the baby is making good respiratory effort, the heart rate is now over 100, you may give the baby some CPAP, or if they're starting to come round, you can just take the mask off and again allow the baby to transition as normal. You give CPAP just by the same method as I've shown, but rather than giving inflation breaths like this, you just hold the mask on the baby, and generally speaking, they'll start to pull the mask off when they're ready to breathe by themselves. If the baby's heart rate does not rise, or you don't see any chest lift, then you have to do some other intervention in order to open the airway and get good chest inflation. The easiest way to do this is to use the 2-person technique. This is very similar to what we have just done, but rather than using one hand to maintain the airway, you use 2. Your thumb and index finger push the mask down, and you use both hands to pull the baby's jaw into the mask, and that is generally effective in creating a tight seal. You will need a second person to then give the inflation breaths in that situation. After giving the 5 inflation breaths using this method, again assess the baby's colour, tone, respiratory effort and heart rate. If after doing a 2-person technique you still have not achieved good chest lift or an increase in heart rate, you can examine the baby's mouth under direct vision and suction anything that you think may be any obvious foreign bodies you can see as shown. You could also consider putting an eye gel airway in if you're competent to do so, and definitely if you've not got senior help by this point, please call for this. Other interventions you could ask somebody else to do whilst you maintain the airway are to put a SATS probe under the baby's hand and also increase your oxygen levels. Normally for normal resuscitation in a term baby we do 21% oxygen, but you can increase it all the way up to 100% oxygen in a resuscitation if you need to. What happens if you have got good chest lift but the heart rate remains less than 60? In this situation, you should now proceed to 30 seconds of ventilation breaths. These are different than inflation breaths, but the airway positioning and how you hold the mask is identical. You give these over 1 second, so you'll do 30 in a 30-second period. These are given as shown. Once the 30-second period is up, you again reassess the baby's colour, tone, respiratory effort and heart rate. If the baby's heart rate and respiratory effort have improved with the 30 seconds of ventilation breath, again you allow the baby to transition or continue to provide CPAP as shown. If, however, there has been no improvement in the heart rate or respiratory effort despite your 5 inflation breaths showing good chest lift and 30 seconds of ventilation breaths showing good chest lift, you then must proceed to CPR. CPR is most easily given in a baby by wrapping both hands under their axilla, placing both thumbs in the centre of the sternum and giving them at a rate of 3 to 1 as shown. 1, 2, 3, and then a ventilation breath. 1, 2, 3, ventilation breath, ventilation breath, ventilation breath. You continue this for 30 seconds and then reassess the baby's colour, tone, heart rate and respiratory effort. At this stage, you definitely need senior help if you do not have it already. CPR can also be given using 2 fingers as shown. 3, 1, 2, 3, 1, 2, 3. However, this is generally a less effective method than the encircling technique. It's a common mistake for inexperienced doctors to jump to CPR when the heart rate remains low, but remember there's absolutely no point in doing CPR on a baby if you have not adequately inflated their lungs yet. So make sure you have given 5 effective inflation breaths, followed by 30 seconds of effective ventilation breaths before proceeding to CPR. Once the baby has been successfully transitioned, again, ensure that there is good thermal care by keeping the baby well wrapped up. They can be brought over to mum for skin to skin, and you then have to decide whether the baby can go to the postnatal ward. Do they need to be in an incubator for a period, potentially with supplemental oxygen, or do they need to transfer to the neonatal unit? Always make sure you update a parent on the resuscitation afterwards, as it's obviously an extremely stressful experience for them, and make sure you document on EPIC following this. I hope this has been a helpful introduction. As I say, I would heartily recommend attending an NLS course, which are very useful, particularly if you're going to be working in PEDS for some time. And I hope that has been a useful video. Many thanks.